An 88-year-old woman is brought into the emergency department by her husband. He describes her becoming increasingly confused over the last week and has noticed increased thirst and frequent urination in the last 2 days. She has a history of type 2 diabetes, hypertension and glaucoma. Her blood results are hemoglobin, 135 grams per liter. White cell count, 10.2 by 109 per liter. Platelets, 335 by 109 per liter. Sodium, 147 mmol/L. Potassium, 4.2 mmol/L. Urea, 27 mmol/L. Creatinine, 173 μmol per liter. Glucose, 37 mmol/L. Her urine dip shows 1+ ketones. Her observations are recorded as heart rate, 89 beats per minute. Blood pressure, 134/76 of a millimeter of mercury. Respiratory rate, 20 breaths per minute. Oxygen saturations, 96% on air. Temperature, 36.5 degrees Celsius. What is the immediate management of this patient's condition? A. Start insulin infusion at 0.05 units per kilogram per hour. B. Start 0.45% sodium chloride solution at 0.5 to 1 L per hour. C. Start 0.9% sodium chloride infusion at 0.5 to 1 L per hour. D. Give 500 ml 0.9% sodium chloride as rapid bolus. E. Start insulin infusion at 0.1 units per kilogram per hour. The answer is C. Start 0.9% sodium chloride infusion at 0.5 to 1 L per hour. The patient has hyperosmolar hyperglycemic state, HHS, elderly patient, history of diabetes mellitus, gradual decline, increased thirst, marked hyperglycemia, hyperosmolality, absence of significant ketonuria. Fluid replacement. Rapid changes in osmolality may be harmful. Use intravenous, IV, 0.9% sodium chloride solution as the principal fluid to restore circulating volume and reverse dehydration. Isotonic 0.9% sodium chloride solution is already relatively hypertonic compared to the serum in someone with hyperosmolar hyperglycemic state. Measurement or calculation of osmolality should be undertaken every hour initially and the rate of fluid replacement adjusted to ensure a positive fluid balance sufficient to promote a gradual decline in osmolality. Fluid replacement alone, without insulin, will lower blood glucose, which will reduce osmolality, causing a shift of water into the intracellular space. This inevitably results in a rise in serum sodium. A fall in blood glucose of 5.5 mmol/L will result in a 2.4 mmol/L rise in sodium. Rising sodium is only a concern if the osmolality is not declining concurrently. Rapid changes must be avoided. A safe rate of fall of plasma glucose of between 4 and 6 mmol per hour is recommended. Thereafter, the rate of fall of plasma sodium should not exceed 10 mmol/L in 24 hours. Low-dose IV insulin, 0.05 units per kilogram per hour, should only be commenced once the blood glucose is no longer falling with IV fluids alone or immediately if there is significant ketonemia, 3-beta-hydroxybutyrate greater than 1 mmol/L or urine ketones greater than 2+, as this indicates relative hypoinsulinemia.